This is Glacier National Park. This is, I think, on the west side where we enter coming in from Kalispell and that. This lecture is Gastritis and Complications. There's the two websites from me and Rome. Dr. Hughes's questions for the USMLE, my Twitter, which my stuff is all posted there. I really want to get back to it. And like I said, I have a very strong interest in general and organ pathology. I really enjoy teaching the medical students. I'm a forensic pathologist, so I see a lot of natural disease in my job, and I think I'm not as specialized in some of the areas like some of the surgeon pathologists. I hope I stick to more general information. Please pause, read this, make sure these disclaimers do not apply to you. If they do, then please don't watch the videos. Once again, pause. Third disclaimer, make sure it does not apply to you. If it does, then don't watch the videos. And like I said, the last one's my introduction. If you want to see my teaching style and stuff like that, it's there. So my list of references, I think these are all great books. I have 2 questions. So once again, pause, look at it, try and figure out the answer. The idea being that you haven't seen this material yet and stuff. And these are supposed to help retention of the material. Same thing, pause, look at it, and we'll discuss it at the end. So gastritis and its complications. So gastritis, inflammation of the stomach. I thought I'd put in stuff here, just some ideas, because the protective things, because you think about it, I mean, your stomach has acid in it. And it's amazing that it can do that, digest your food and not digest itself. And it does that because it secretes mucus, it secretes bicarbonate, it secretes you have adequate mucosal blood flow, the production of prostaglandins, and then the epithelium can regenerate. The damaging effects are if you have hypersecretion of gastric acid that can overcome the body's protective mechanisms. If you have direct damage to the mucosa, as alcohol, smoking, and ischemia can do, decreased mucus production, and decreased bicarbonate secretion, which comes from nonsteroidals, and then also the urease-producing H. pylori. The ammonium that they produce inhibits bicarbonate transporters, so you have less bicarbonate and you don't have that protection. So this kind of gives you the protective side of it and that how that goes wrong, and then specific things that can affect the mechanism of that protection, and then you develop gastritis. So here's my little diagram for kind of showing how the mechanism of nonsteroidals work. They basically inhibit cyclooxygenases production of prostaglandins E2 and I2, and then those play a role in the bicarbonate secretion, which is important, the mucus secretion, which is important, blood flow, adequate blood flow is needed, and also regrowth of the epithelium. So acute gastritis, gastropathy. So this can be very subtle and also like hardly present at all with inflammation and stuff like that. 2, I've seen where they talk about a hemorrhagic gastropathy where you see actual hemorrhage and stuff, which would be a little more obvious. But with acute gastritis, obviously acute and inflammation be neutrophils. And then gastropathy, they said characteristically the cells are injured, but there's no or few inflammatory cells. So it could be very difficult, I think, to identify. And then just things we've been talking about, nonsteroidals through their effects on removing the protective mechanisms of the stomach, alcohol damaging directly the mucosal cells, and then bile reflux. I mean, bile is designed to carry fat, and it has bad effects on cells in that. So this will go along the lines with the hemorrhagic gastropathy, I think, kind of, or that spectrum of stuff, what are called stress ulcers. So if you have a decreased pH in the blood, so more acidic, then that's going to lead to a decreased pH in the mucosa, which is not good. Hypoxia ischemia, remember ischemia will directly damage the cells, obviously. And then vagal stimulation due to a brain injury can lead to hypersecretion of acid. And so what this does is that these are not peptic ulcers, as we'll talk about, with those being a chronic complication of like a chronic gastritis or that. These are just very superficial, and it's very common for us to see these at autopsy, obviously. You can see they develop due to stress, so people with severe physiologic stress. People with burns develop curlings. People with intracranial develop Cushing. To me, I think it's just the name. The appearance of it could be very similar, difficult to completely separate out, but just the association. So forensic pathologists see these quite frequently because we see those categories of patients, people with very severe stressors and who ultimately die. Chronic gastritis. Most commonly H. pylori, non-steroidals, and then autoimmune. A small percentage of people can get autoimmune. Other things can do it as well too. You could imagine radiation is just damaging. Indwelling catheter, if you have something that's inside the stomach that's hitting it, would cause inflammation. Crohn's disease normally involves usually the small intestine, colon, but can involve any part of the GI tract. So with chronic gastritis, inflammation of the stomach can cause nausea, you can imagine, and then upper abdominal pain, kind of epigastrum pain. Morphologically, you'll see inflammation and then mucosal atrophy in response to it. And then obviously dysplasia can occur, and it can be a precursor for potentially contributing to carcinoma. Complications, ulcer. Chronic gastritis can lead to a peptic ulceration. Just mentioned about mucosal atrophy and intestinal metaplasia in response. And then the dysplasia, neoplasia, the hyperplasia, dysplasia, neoplasia, metaplasia, dysplasia, neoplasia, and can contribute to colonic polyps, as we talked about. Gastric polyps. Chronic gastritis, so this just shows microscopically. So you can see the stomach glands, and then scattered in between all throughout, you see chronic inflammatory cells. So this is just another one of Glacier National Park. It's one of the rivers up there. H. pylori-induced chronic gastritis. So when we talk about this, it was honestly a little bit confusing to me because autoimmune gastritis is more known for affecting the parietal cells, but this is from baby robins, which is derived from big robins. And it basically says that CD4-mediated damage to parietal cells plays a role in the mechanism of H. pylori-induced chronic gastritis. And that inflammation damage to the parietal cells promotes increased gastrin production, which you can imagine. So if you knock out the parietal cells, which are producing acid, it's going to feed back to tell the body to produce more gastrin, which is going to produce more acid. That leads to hyperplasia of those parietal cells and then increased acid secretion. And then when you see things like metaplasia, atrophy, and stuff like that, that's more obviously late term. Some things that are bacterial specific, it says motility allows H. pylori to be more effective at this. It's adhesion factor, so it can stick to the mucosa cells, it makes sense. The urease production, because like I said, it generates ammonia, and then that blocks the bicarbonate secretion, which is going to affect the ability of the stomach to moderate the acid. That's CAG-A toxin, promotes pro-inflammatory cytokines. So those come from the bacteria itself. It's most commonly in the antrum, and then complications, it can lead to peptic ulceration. With it, you can have hemorrhage and so anemia. It can lead to a B12 deficiency due to the inability of the body to produce enough intrinsic factor to absorb B12. It can lead to, because you have inflammation going on, that can contribute to a dysplasia, which can contribute to carcinoma. So just remember, it seems like anytime you have chronic inflammation, for the most part, you are at greater risk for a neoplasm, because the chronic inflammation is going to promote cellular turnover. Anytime you have cellular turnover, you have potential for mutations, and mutations can lead to carcinoma. So diagnosis, I just put them in there. You can have anti-H. pylori antibodies. They can test for it in the stool, urea breath test, or if need to, gastric biopsy. So another one, this is much less common, is an autoimmune gastritis. So I listed up here what I could find the difference between the two. So you have a chronic gastritis due to H. pylori. It can be due to NSAIDs, but sometimes it's due to autoimmune, much less common. So this is H. pylori versus chronic gastritis. This is autoimmune gastritis versus H. pylori associated chronic gastritis. So everything listed here is what you see in autoimmune, comparing it to H. pylori. So it's much less common than H. pylori-induced chronic gastritis. It spares the antrum, whereas H. pylori is known for affecting the antrum. You see marked hypergastrinemia. You can see some hypergastrinemia in H. pylori chronic gastritis, but not nearly as much as you see in autoimmune. Is due to antibodies to parietal cells. So that could be one of the reasons why you see that marked hypergastrinemia, because it has a much greater effect on the parietal cells. It can cause achlorhydria because you have damaged parietal cells, you don't secrete acid, and you're not making intrinsic factors, so you get B12 deficiency. Obviously, from its name, it's associated with autoimmune, so autoimmune diseases tend to travel in groups, and so if they have one autoimmune, there's a good chance they have other ones, and then women are much more commonly affected by autoimmune disease than males, and it's usually an older age population. Okay, one effect of chronic gastritis, one complication would be peptic ulcer disease, and this is commonly associated with H. pylori, with non-steroidals be the two main risk factors for it. It's usually middle to older age adults, males greater than female. Clinical features, epigastric pain, usually 1 to 3 hours after a meal, and it's worse at night. So there's something about gastric versus duodenal, but what I was reading in another book was that the association with meal and gastric versus duodenal is really not that great. So you're probably not going to completely separate it out. You can get chronic renal failure and hyperparathyroidism. It says hypercalcemia promotes gastrin production. And so basically, if somebody has hyperparathyroidism, they're going to have hypercalcemia, and then that's going to promote gastrin production, which is going to produce more acid, which is going to lead to the risk for peptic ulcer disease. So obviously, they can bleed. They can bleed over time, be anemic. They can bleed all at once, become hemorrhagic, and then it can perforate through the wall of the stomach, and it can lead to peritonitis. So here are two. To the top left, this was a gastric peptic ulcer. To the right was a duodenal peptic ulcer. And you can see they're usually described as punched out, meaning that the edges of it go right up to the level of the mucosa. If you see heaped up margins at an ulcer, so it looks like there's a little ridge around the ulcer, that would be concerning for something like a neoplasm, for an ulcerated neoplasm. So usually we'll sample those carefully if they have a heaped up margin. Top left is a duodenal peptic ulcer, person that hit a vessel and they bled from that. Bottom right, this person actually has multiple peptic ulcers. You can see at the arrows, the white arrows, those are 2 of them. So one thing when you have multiple peptic ulcers, you want to consider Zollinger-Ellison syndrome, which is basically a neoplasm producing gastrin, so it would lead to acid secretion. And so they can have multiple ulcers and also are known for having ulcers in unusual locations. So this is microscopic of it. The top left, the ledge that you see left there is the actual normal stomach, and then the ulcer bed. So you can see it just goes to the edge of the stomach and goes straight down. So that's that punched out appearance. And then the bed of it, you're going to see, depending upon the stage of it, you're going to see a variety of things. Acute inflammation, chronic inflammation, fibrosis, granulation type tissue. You can see fibrin. Usually probably the further out you are, or I'm sorry, the more at the bed you are, the more at the surface you are, the more you're going to see the fibrin and acute inflammatory cells. And as you go deeper into it, more chronic inflammation, fibrosis, and that. And I've seen them where you can see a cross-section. You can see where vessels are. You can see where they hit the vessel and bled from that. So a hypertrophic gastritis, 2 things that are associated with it are Menetrier's disease and that Zollinger-Ellison syndrome. I talked about Zollinger-Ellison syndrome, so we'll leave it there. I used to spell it Ellinson, E-L-L-I-N-S-O-N. I saw that was wrong, so I went through and removed all the N's I could. I hope I didn't miss any. There are other forms of gastritis. You can see eosinophilic gastritis. So with chronic gastritis, usually we're talking about lymphocytes, but you can see eosinophilic, you can see lymphocytic, you can see granulomatous, other ones, and so there are other forms. Okay, so first question, pause, and then we'll go through it. 45-year-old male non-smoker who has had recurrent bouts of epigastric abdominal pain over the past 3 years is brought to the emergency room by his wife. About 15 minutes ago, he vomited a large amount of blood in the kitchen. His vital signs are blood pressure of 85 over 60 millimeters mercury, heart rate of 110 beats per minute, and respiratory rate of 22 beats per minute. He is pale. Of the following was the most likely diagnosis, so it would be a bleeding peptic ulcer. A Delafoy's lesion is a abnormally dilated vessel, which can cause GI bleeding, but would be really rare compared to a peptic ulcer. Mitral stenosis can lead to coughing up of blood. A ruptured thoracic aortic aneurysm could potentially rupture. If there's a fistula or something like that, could potentially rupture into the GI tract or could be misinterpreted bleeding. So it's possible, but there's no risk factors for it. And then Marfan syndrome, same thing. So of these choices, given the fact that he has had recurrent bouts of epigastric abdominal pain over the past 3 years, there's a good best choice would be a bleeding peptic ulcer as to why he's having this sudden bleeding now. Okay, so pause and we'll do the answer. A 43-year-old male presents to his family physician complaining of abdominal pain. He describes that the abdominal pain is burning, epigastric in location recurrent. Often anemia will relieve the pain. His only past medical history is hypertension treated with an ACE inhibitor, and he is on no other medication. Of the following is the most likely etiology for this condition. So the thing would be H. pylori. So with the epigastric pain, he's having chronic gastritis. He probably has potentially an ulceration with eating the meal and relieving it, and also the chronic abdominal pain. And then of those, H. pylori and non-steroidals would be the two most common as far as underlying etiology for a peptic ulcer. Okay, so reflection once again. Pause, go back through the lecture, think of 5 important points that you've learned from this. I hope there have been 5 important points you've learned from this. Like I said, this is a really great technique for kind of cementing the material. So I highly recommend it. This was on the lake we were on. We were going around on a pontoon boat. It's a real slow moving boat, lets you enjoy the scenery and everything like that and the sunset. And so just kind of pretty that night. So I hope you have enjoyed the lecture. I hope you've learned from the lecture. And thank you.